Good afternoon, everyone. I'm Tyral, and as Jeremy said, I'm going to be talking about enterococcal infections. I've entitled my talk An Old Dog with New Tricks, which we'll shortly see why. So with regards to the outline of the talk, I'll first take you through the history and the microbiology, and then we'll touch on a little bit about the epidemiology. We'll look at some local stats, and then we'll look at the spectrum of enterococcal disease, as well as the mechanisms of resistance. And then we'll speak a little bit about infection prevention and control, and then lastly about whatever treatment approaches or treatment options we have available to us. Okay, so taking you a little bit into the history, the term Enterococcus actually has its origin as far back as the end of the 19th century, when a gentleman by the name of Thiocelin described a saprophytic coccus of intestinal origin, which was capable of causing infection. And this was in around 1899. So that's the picture of Thiocelin there on the left. And then that same year, two other gentlemen by the name of McCallum in the middle and Hastings on the right, they had characterized a similar organism that we now know to be as Enterococcus faecalis, and this was from quite a lethal case of enterococcal endocarditis. And this case, was the first detailed description of the pathogenic capabilities of Enterococcus. So we fast forward about 100 years later, and now we see multi-drug resistant enterococci have emerged. And this multi-drug resistant enterococci contributes quite significantly to the burden of nosocomial infections all across the world. In terms of the microbiology, enterococci are actually gram-positive, facultatively anaerobic cocci that form short to medium-length chains. In around the 1930s, Lansfield actually devised a serologic typing system that classified Enterococci as group D streptococci, along with some other organisms like Strep galloliticus. And these cocci differed from Enterococci in a number of ways, which we'll speak about now. Then in 1937, there's a gentleman by the name of Sherman who divided streptococci into the pyogenic, the viridans, the lactic, and the enterococcal groups. And enterococci were characterized by a few specific features. This is their reaction to, or their ability to react with group D antiserum, their ability to grow at high salt concentrations and at 10 to 40 degrees Celsius, given at high pHs, and their ability to survive exposures to temperatures up to 60 degrees Celsius for as long as 30 minutes, and their ability to hydrolyze esculin in the presence of bile. In the ensuing 45 to about 50 years, Enterococci continued to be taxonomically classified under the genus Streptococcus, but in the mid-1980s, with advances in taxonomic techniques, largely based on DNA techniques, it was proposed that Strep faecalis and Strep faecium be removed from the genus Streptococcus and then transferred to the new genus Enterococcus, and to be reclassified now as Enterococcus faecalis and Enterococcus faecium. And then subsequently, other enterococcal species were also reclassified from the genus Streptococcus to Enterococcus, and dozens of new species have actually been recognized to date. So Enterococci are actually GIT commensals, and they're quite hardy, and this hardiness has actually allowed them to colonize a diverse environments, which would include things like soil, food, water, animal feed. And their ability to overcome adverse conditions makes them quite problematic once they colonize hospital environments. Their genomes seem to be quite malleable, and with this malleability of their genomes and their capacity to acquire and disseminate resistance, it's contributed quite largely to what was just once thought another opportunistic pathogen to a first-class clinical problem. We know that rising antimicrobial resistance is a threat to global health as a whole, and surveillance of antimicrobial resistance from a One Health perspective is quite important for control and for management strategies. The natural intrinsic ability of enterococci to resist multiple classes of antimicrobials, which we'll go through, enables them to be quite persistent and to survive across this One Health continuum. In some texts, it's actually suggested that enterococci can serve quite well as an indicator to monitor AMR from this One Health context. In terms of epidemiology, the prevalence of hospital-acquired infections caused by Enterococcus is said to be about 3.3 to about 12.5 cases per thousand in the European Union. And there's similar data coming out of Australia with about 8 per thousand cases, and then a little bit fewer in Latin America, 4 per thousand patients. This is in contrast to lower prevalence settings like the US and China, said to be about 1.9 and 1.3 cases per thousand hospital patients, respectively. So now if we look a little bit at our local data, so this was actually a study from 2021. It's a cross-sectional analysis of culture-confirmed enterococcal bloodstream infections. And this was based on data obtained from the NHLS between the time 1st January 2016 till 31st December 2020. And this was done by our colleagues at the NICD. I'm sure you recognize a few of the names. And we can notice that there's an upward trend from about 2018 onwards with an equal sex distribution. In terms of the age distribution, most isolates during this time period were observed in children under the age of 1. And the paper didn't really have much clinical data to delve into this and explore it further, but we know that there's usually this bimodal distribution in under 1 and then in adulthood again. In terms of distribution between the provinces, we can see Gauteng had the highest number of cases, and it was probably owing to it being so populous. In terms of the species, we can see Enterococcus faecalis and faecium being the top two culprits, 50% faecalis and 45% faecium. This data is taken from the National Department of Health, the AMR surveillance report of 2023, and it looks at the escape, this graph looks at the escape pathogens detected in the public sector between 2018 and 2022, and we can notice quite a steady increase in Enterococcus isolates with a small drop in 2022, and we can see they account for the 4th and the 5th common cause of hospital-acquired drug-resistant infections. And then in terms of resistance in numbers, we can see this is again surveillance data from the same paper looking at vancomycin-resistant isolates. And you can see 1.3% rather in Enterococcus faecium isolates, and 1.1% of bloodstream infections were said to be vancomycin resistant during this time period. Then I've taken this data from the NHLS, the NICD dashboard rather. So this is from 2023, and we can see that we've reported about 108 isolates of vancomycin-resistant Enterococcus, and the highest of which was in Gauteng with 53 isolates in public and 10 in private. Okay, so in terms of spectrum of disease, enterococci can cause quite a variety of infections, and they can include bacteremias, endocarditis, intra-abdominal infections, pelvic infections, skin and soft tissue infections. And then there are some other less commonly defined infections like septic arthritis, osteomyelitis, and even meningitis. In terms of urinary tract infections, so the most common type of enterococcal infection occurs in the urinary tract, and lower urinary tract infections like prostatitis, cystitis, and epididymitis are frequently seen in older men. Enterococci are not a very common cause of uncomplicated cystitis in young women, but upper urinary tract infections do occur, most commonly in older men, and they can lead to bacteremias. Enterococcal urinary tract infections are more likely to be acquired in hospital or long-term care facilities, and they are thus likely to be more resistant to antimicrobials. In the ICU setting, enterococci cause about 15% of healthcare associated urinary tract infections, and not unexpectedly, VRE has become a major healthcare associated urinary tract pathogen in ICU patients. In terms of intra-abdominal, pelvic, and soft tissue infections, they're often recovered from these sites, and they are almost always isolated as a component of a polymicrobial infection rather than monomicrobial infections at these sites. Obviously, if you have abscesses or soft tissue infections, drainage of the abscesses and debridements of the wounds are essential to address source control. Peritonitis can occur most often in patients with some underlying liver disease like cirrhosis, or in patients who are on chronic peritoneal dialysis. And in these situations, enterococci can cause a monomicrobial infection, although it's far less common than E. coli for spontaneous bacterial peritonitis, and far less common than coagulase negative staphylococci or Staphylococcus aureus for dialysis-associated peritonitis. Enterococci are also sometimes found in decubitus ulcers and foot ulcers, as well as, like I said, osteomyelitis in diabetics. But again, their role in infections at these sites is not really very well defined. In terms of bacteremias, so bacteremia and endocarditis are the more common manifestations of enterococcal infections, and they are currently the fourth and the fifth leading cause of healthcare-associated bacteremia in our setting, like I showed you in the escape pathogens graph. But they are said to be quite higher up on the list in other hospital settings. The source of a bacteremia is usually genitourinary tract in origin, although a bacteremia can sometimes arise from intra-abdominal or biliary sources, from indwelling central lines, or even from soft tissue infections. They can also be found, as I said, as a component of a polymicrobial infection more often than other organisms. And bacteremias, in contrast with Staph aureus, bacteremias rarely seed to distant organisms, so you don't often find metastatic disease with enterococci. But the major issue with dealing with enterococcal bacteremia is really the presence of endocarditis, which is why astute clinicians will pay very close attention to the heart in patients with an enterococcal bacteremia. Patients who are at risk for developing enterococcal bacteremias are older adults, those with multiple underlying diseases, which can include things like diabetes or underlying malignancy, underlying heart disease, transplant recipients, and patients who have had surgical intervention previously. Endocarditis is one of the most serious enterococcal infections, and overall causes, or said to cause, between 5 to 15% of cases of infectious endocarditis, with fecalis being more common of the two. And because of enterococci's intrinsic resistance to bactericidal activity of many antimicrobials, treatment is often difficult, and even when relatively susceptible enterococci are isolated. So usually 2 drugs that exhibit synergistic killing are required for effective therapy in these cases. In situations with vancomycin-resistant enterococci or high-level aminoglycoside-resistant enterococcal endocarditis, antibiotic treatment can sometimes fail, and surgery then becomes quite necessary to remove the infected valve. The initial source of bacteremia leading to endocarditis is usually genitourinary or gastrointestinal in origin, and left-sided involvement is said to occur much more commonly than right-sided involvement. In terms of prosthetic valve endocarditis, so there's been an increase seen, and it's said to be related to the increasing use of prosthesis in older adults who are at an inherently higher risk for enterococcal bacteremias. The clinical picture of Enterococcus endocarditis is usually, well, the patients would usually present with a subacute infection and sometimes in heart failure, and not very often with embolic complications, but they can progress quite rapidly. The most problematic current issue in managing these patients is really selecting an effective therapy for multi-drug resistant isolates, which we'll touch on a little bit later. So the bottom graph that I included on this slide was a study from the Lancet in 2022. And this was actually a retrospective analysis, and 42 studies were included, and the pooled culture positive isolates were shown on this chart. And you can see that around 9% of these isolates were attributed to enterococcal infection, which seems to be quite high compared to this graph here. So I'm sure you recognize this pie chart was from the culture negative endocarditis study from Cape Town. And this pie chart superimposes the cases that were culture positive with the culture negative pathogens that were subsequently identified using PCR techniques like 16S rRNAs. And we can see here 2% prevalence of enterococcal endocarditis. Is this a reflection of national data? I don't know. It may very well be. But this is what we have with our endocarditis data. In terms of other uncommon sites of infection, so other infections less commonly seen, less commonly or rarely seen are things like meningitis or hematogenous osteomyelitis, septic arthritis, and even pneumonias. Pneumonias are quite rare, even in association with ventilators or VAPs. And they really have only been documented in severely ill, debilitated patients who are immunocompromised and having received extended duration of broad spectrum antibiotics is said to be a risk factor. In terms of mechanisms of resistance, so the problems with treating enterococcal infections were first noted very early on, like I said, in the early 1950s, with the observation that enterococcal endocarditis wasn't cured as readily with penicillins as streptococcal endocarditis was. And the reason for the poorer response appears to be that penicillin is not as bactericidal against enterococci as it was or is still as it was in the 1950s or still is. Against most viridans group streptococci, that is. So this phenomenon has been described as tolerance in the literature, and it's characteristic of many enterococcal strains, even in those that don't initially display tolerance. Tolerance can be rapidly produced by exposure to penicillins. So I've taken this from the WHO list of priority pathogens of 2024, and you can see vancomycin-resistant Enterococcus faecium appears at number 3 on the high group or high risk pathogens. And we can see again that VRE has moved from position 9 to position 11 between 2017 and 2024. Seems to be becoming more and more of a problem as we go on. In terms of genetics of resistance, so some enterococci have now acquired resistance to many antimicrobials as a result of mutations or the acquisition of new genes. Many of the acquired resistances of enterococci involve antibiotics that are not often used to treat enterococcal infections. And these antibiotics would include things like tetracyclines, macrolides, clindamycin, rifampin, and fluoroquinolones. And it seems like that these resistance patterns have emerged among enterococci that were colonizing humans and animals to whom antibiotics were given for other reasons, so not necessarily to treat enterococcal infections. And this is how the resistance has emerged. With regards to the acquisition of new genes, there are several different ways of transferring DNA by conjugation that's been described. So one mechanism is involving pheromone-responsive plasmids, which causes plasmid transfer between Enterococcus faecalis isolates, and this is said to happen at very high frequencies. And then another mechanism involves other plasmids that can transfer across species and genera, although this is said to occur less frequently. A third mechanism that's been described is conjugative transposition, which involves transfer of specialized transposons to a broad range of bacteria. And conjugative transposons are one of the few types of elements known to have crossed the gram-positive, gram-negative barrier in naturally occurring clinical isolates, and then to cause resistance in the host subsequently. The fourth mechanism involves the transfer of large fragments of chromosomal DNA directly from one cell to the other via conventional conjugation. In terms of beta-lactam resistance, so relatively little penicillinase is produced by Enterococca, and because of the rarity of penicillinase producing positive Enterococci, the CLSI only really recommends to test for it in selected cases. And these selected cases would be cases of endocarditis or other serious infections. Although identification of penicillinases doesn't actually appear to be a therapeutic issue, since BLIs like tazobactam or ampicillobactam and other drugs like vancomycin can still be used even in its presence. The intrinsic resistance of Enterococcus faecium appears to be due to the presence of a cell wall synthesis enzyme that is resistant to inhibition by penicillin. And this low affinity penicillin binding protein is called PBP5. And there's actually two versions of it, designated R and S. R typically is observed in strains that are hospital acquired or hospital associated Enterococcus faecium isolates with high MICs for ampicillin. And then S is typically found in non-clinical or community acquired strains that confers lower MICs for ampicillin. So high levels of resistance to beta-lactam antibiotics appear to involve either an increased expression of this PBP5R or alterations in the PBP5 protein around the active site. Enterococci are also intrinsically resistant to cephalosporins with the high MIC for the majority. Lower MICs are seen with the newer cephalosporins like ceftobipro or ceftaroline. And intrinsic resistance to cephalosporins in fecalous isolates is quite complex, but has been tied to a number of proteins that impact cell wall synthesis. In terms of aminoglycoside resistance, so Enterococci are intrinsically resistant to low to moderate levels of aminoglycosides. However, synergism is generally seen when Enterococci are exposed to a combination of aminoglycoside therapy with a cell wall active agent like penicillin or vancomycin. A characteristic of PCM is high MICs to the drug tobramycin, and resistance to synergism with this aminoglycoside. And this is due to the presence of an aminoglycoside modifying enzyme called tobramycin 6-acetyl transferase. And this modifies tobramycin, but has really no effect on gentamicin. So gentamicin can still be used even in its presence. So other Enterococci will possess this APH3 prime gene, which confers high-level resistance to kanamycin and sometimes abolishes any synergistic effect that amikacin may have. And it's thus suggested that with some minor exceptions, that gentamicin and streptomycin are the only two aminoglycosides that should be considered to achieve adequate synergistic therapy when treating enterococcal infections. But having said that, there has been high-level resistance to streptomycin and gentamicin, which appears to be the most serious forms of acquired resistance with enterococcal infections. In terms of trimethoprim sulfamethoxazole and clindamycin resistance, so trimethoprim and sulfamethoxazole are both inhibitors of folic acid synthesis. And folic acid we know is necessary for bacterial growth and survival. In vivo resistance of Enterococci to bacterium in animal models appears to be due to the fact that these organisms, unlike other bacteria, can actually use preformed folic acid. So this is folic acid that is readily available for the use from the human and the animal host. Acquired high-level resistance has been seen in some enterococcal isolates to bacterium. Clindamycin, on the other hand, there has been low-level resistance to clindamycin, and this is usually due to this LSA gene, which seems to be a naturally occurring trait in some of the strains. In terms of linezolid, the G2576U, so this is a confusing E. coli numbering scheme, but a mutation in the domain 5 of the 23S rRNA is the most common mutation associated with linezolid resistance, because we know that 23S rRNA is the target site for linezolid. And plasmid-mediated resistance is actually involving methylation at specific sites on this 23S rRNA domain. So oxazolidinone resistance among enterococcal isolates has been increasingly documented, and linezolid resistance, which was initially described as sporadic, is now seeing more often with prolonged use of the antibiotic. In terms of vancomycin, so vancomycin inhibits enterococci by binding to the D-alanine terminus of the cell wall precursors, compromising the subsequent enzymatic steps in synthesizing the cell wall. High-level resistance to vancomycin is encoded by different gene clusters, which we might have seen before, Van A, Van B, and Van D gene clusters. And the end result is really a replacement of D-ala ending peptidoglycan precursors with D-alanine D-lactate termina, to which vancomycin binds with significantly lower activity. So there's the change there in domain to D-alanine D-lactate, and there seems to be a lower affinity for vancomycin binding to D-alanine D-lactate. The CLSI actually describes susceptible isolates as being less than 4 micrograms per mole, with resistant isolates more than 32, and an MIC of between 8 and 16 is considered vancomycin intermediate, and it's not suggested to be used in these cases. So after vancomycin-resistant enterococci have been introduced into the healthcare setting, transmission is often determined by selective pressure, which can be due to antimicrobial use, the proportion of colonized patients, the availability of susceptible patients, and the adherence to any efforts to prevent spread of infection. The risk will obviously significantly increase in an ICU, and this is said to be once the proportion of patients infected exceeds 50%. VRE colonize the GIT and can be found on the skin after fecal shedding. And colonization with VRE generally precedes infection, but not all patients with colonization actually become infected. But people either colonized or infected with VRE can obviously serve as sources for secondary transmission. There have been PCR techniques to identify Van A and Van B genes that I just discussed in the previous slide. And these PCR techniques are usually done on stool and rectal samples. So they have been developed, but their impact on surveillance for VREs is not very well defined, and I think is yet to be determined. And then in terms of transmission of VRE, we know that it can occur by both direct contact, that's with like the hands of healthcare workers, or indirectly from contaminated surfaces, which is why infection prevention and control is such a key player. The most commonly observed risk factor for hospital acquisition of VRE is usually previous treatment with antimicrobials, particularly with vancomycin and cephalosporins. And the use of multiple agents with a broad spectrum of activity may predispose patients to colonization with drug-resistant enterococci. And this is probably via alteration of the patient's normal bowel flora. Patient characteristics include those that have been hospitalized for longer than 72 hours, if they have any significant underlying medical conditions like end-stage renal disease requiring dialysis, cancer, transplant recipients, if they require ICU for whatever reason, then also things like proton pump inhibitor use and invasive devices have been said to be risk factors as well. Then obviously exposure to contaminated surfaces in patient rooms, even after routine terminal cleaning, can also be associated with VRE acquisition, and transmission of VRE from environmental surfaces to hands and gloves of healthcare workers has been very well described and documented. Residents of long-term care facilities appear to be a reservoir for VRE, and risk factors for them include prior use of antimicrobials and sometimes even the presence of a contaminated decubitus also. In terms of VRE infection control, so prevention of infection, as with any multi-drug resistant organism, requires this multifaceted approach, which would include general infection prevention, like optimal management of vascular and urinary catheters, accurate and prompt diagnosis and treatment of infection, and also the prudent use of antimicrobials, together with the prevention of ongoing or onward transmission. So methods of transmission prevention would include good hand hygiene, and this is, for example, hand washing with an alcohol-based hand rub or chlorhexidine-based soaps, contact precautions. You may cohort colonize to infected patients, and also ensuring adequate source control in index patients, and then obviously employing appropriate surveillance strategies. Okay, so we'll move on to treatment approaches. So generally, enterococci are less susceptible to penicillin and ampicillin compared with most other streptococci. Even when these cell wall active agents inhibit enterococci, they don't often kill them. The enterococci are relatively impermeable to aminoglycosides, and the serum concentration of aminoglycosides required to achieve bactericidal activity are much higher than what can be safely achieved in humans. But the simultaneous use of a cell wall active agent, like I said, raises the permeability of the cell so that appropriate intracellular bactericidal aminoglycoside concentration can actually be achieved. Bactericidal antimicrobial activity is very necessary, obviously, in the clinical circumstances of life-threatening enterococcal infections like that of endocarditis, for example. To rule out the possibility of beta-lactamase production in patients with life-threatening enterococcal infection like meningitis and endocarditis, some experts do recommend that the isolate be screened for beta-lactamase production with a chromogenic cephalosporin, even if the isolate has tested ampicillin susceptible. Patients with enterococcal endocarditis and an unclear source of infection appeared to warrant a colonoscopy. And this was actually suggested in a retrospective study where about, I think it was 140 odd patients with infective endocarditis due to fecalis underwent routine colonoscopy. And the overall rate of colorectal disease was said to be as high as 70%, with the prevalence of advanced adenomas and colorectal carcinoma was as high as 14%. So these numbers seem quite high, and this was actually the study was quoted in up-to-date treatment approaches. So I haven't had a chance to scrutinize this data, but it seems to be quite significant and significant enough to adjust up-to-date recommendations that most people or patients with enterococcal endocarditis, elderly patients with enterococcal endocarditis that have no clear source of infection you should consider colonoscopy in these patients. That would be reasonable. So traditionally, the standard of care for severe enterococcal infection, like endocarditis, has been penicillin or ampicillin combined with an aminoglycoside, again, to generate the synergistic bactericidal activity. But a newer regimen, the combination of ampicillin and ceftriaxone, has yielded clinical cure rates that seem to be quite equivalent to that of ampicillin and gentamicin for fecalis endocarditis. And this is regardless of whether the isolates expressed high-level aminoglycoside resistance. So the combination of ampicillin and ceftriaxone is favored by quite a few, and this is mostly because it avoids, the toxicity that comes with aminoglycoside use. So in fact, the ESC guidelines will recommend either AMPI or ceftriaxone or AMPI and gentamicin as first-line therapy for enterococcal endocarditis. So ampicillin or penicillin are preferred cell wall active agents to use with an aminoglycoside, and vancomycin should be substituted in the setting of high-level beta-lactam resistance, or if the patient has demonstrated any hypersensitivity to beta-lactams with an inability to desensitize. Coming back to the major categories of resistance. So remember, we said there was high-level penicillin resistance, then there's high-level aminoglycoside resistance, and then there's vancomycin resistance. So in terms of therapy for high-level penicillin resistance, so when bactericidal activity is needed, again, in the setting of like endocarditis, so vancomycin, in some texts, teicoplanin where it is available, or even daptomycin IV could be considered to be used together with an aminoglycoside. In the presence of high-level aminoglycoside resistance and with the concern for nephrotoxicity, there is a recommendation for high doses of daptomycin. This is 10 to 12 milligrams per kg IV. And daptomycin may also demonstrate a synergism with or enhancement by agents like ampicillin. In terms of high-level aminoglycoside resistance, linezolid, in terms of vancomycin resistance, linezolid can be used for treatment of infections caused by vancomycin-resistant enterococci. And linezolid for the treatment of endocarditis is uncertain, although there are some anecdotal cases suggesting some utility. So certainly in our setting where we have very limited access to other drugs that we can use, we have tried linezolid in VRE isolates with some success. Linezolid is again mentioned in the ESC texts, but I think because of the lack of evidence, it's not a clear-cut recommendation in their treatment tables. But having said that, the resistance profile for VRE isolates should be evaluated very carefully, and the approach to treatment in such isolates should be assessed on an individual case and obviously discussed with your microbiologist and ID clinician. For vancomycin-resistant FECM, they often have concurrent high-level resistance to beta-lactams and aminoglycosides. In contrast, vancomycin-resistant E. faecalis are usually susceptible to penicillin and ampicillin, but the newer agents, linezolid, daptomycin, tigecycline, all have activity against vancomycin-resistant Enterococcus faecalis and FECM. In terms of UTI, so UTIs with Enterococcus generally don't require bactericidal therapy, and urinary catheter-associated bacteriuria often resolves with just removal of the catheter. But if a patient warrants therapy, there's quite a few options. The preferred oral agents, amoxicillin, nitrofurantoin, a single dose of fosfomycin is sufficient as monotherapy. In terms of meningitis, so enterococci rarely cause meningitis in healthy adults, and most cases of meningitis occur in patients with head trauma or neurosurgery or intraventricular intrathecal catheters, or even patients with anatomical central nervous system defects. It can be seen in the setting of neonatal sepsis and has also been associated with strongyloides hyperinfection, interestingly. But in terms of approaching a patient with enterococcal meningitis, the treatment is not very clear, but usually combination therapy is suggested. So for infection to Enterococcus faecalis, treatment usually with triple drug regimens such as ampicillin with ceftriaxone and with gentamicin is suggested. And obviously this is assuming that there's no high-level gentamicin resistance. If patients are failing to respond to systemic antimicrobials, there is some limited evidence for the addition of intraventricular antibiotics, and this is vancomycin or daptomycin with or without gentamicin. Daptomycin has very poor CNS penetration if it is used for CNS infections. So daptomycin should maybe be considered to be used both intraventricularly as well as intravenously. In the treatment of enterococcal meningitis caused by Enterococcus faecium strains resistant to penicillins and aminoglycosides, penicillins, aminoglycosides, and vancomycin, this becomes quite a tough challenge. But here, I think you do have the option of linezolid. Tigecycline, on the other hand, has been used in some case reports with either intraventricular daptomycin or intraventricular tigecycline, but again, the evidence here is very poor. In terms of duration of therapy, the IDSA suggests 10 days for meningitis or ventriculitis, and this can obviously be extended if the patient proves to be persistently culture positive. In terms of other drugs, so oritavancan, I hope I'm saying it correctly, is a semisynthetic glycopeptide that inhibits cell wall synthesis and has some in vitro bactericidal activity against Staphylococcus and Enterococci, including vancomycin-resistant strains. But the activity seems to be increased against some vancomycin-resistant enterococcal strains by an aminoglycoside. But there's no real trial data to support its use in VREs, although there has again been some anecdotal reports of its successful use. In around, I think, 2014, it was approved by the FDA for acute bacterial skin and skin structure infections due to susceptible organisms. And the advantage of this drug is that it has quite a long half-life of about 100 hours, which would allow for single-dose therapy for skin and soft tissue infections. In terms of the newer generation tetracycline derivatives, like I mentioned, tigecycline does not have FDA approval for treatment of VRE, although it has been approved for treatment of complicated skin and soft tissue infections and intra-abdominal infections, including infections with vancomycin susceptible fecalis. We know that tigecycline has a large volume of distribution, and there are thus concerns regarding its ability to achieve decent serum concentrations, and therefore it's not often or not at all suggested for the use of in patients with enterococcal bacteremias. It may, however, prove to be useful in patients with VRE who seem to be intolerant to other agents, or when VRE are present with other pathogens in like a polymicrobial intra-abdominal infection, for example. So in addition, tigecycline can also be useful if you're treating infections of the biliary system. So that's if the source is in the biliary system. And that's because the drug is eliminated almost completely by the hepatobiliary tree. And then another case would probably be in the setting of renal insufficiency, where tigecycline is less nephrotoxic or safer than other drugs that you might be considering. Eravacycline is approved again for complicated intra-abdominal infections due to susceptible fecalis and faecium isolates. And the other drug, omadacycline, is a new oral tetracycline that's also been approved for skin and soft tissue infections and for community-acquired pneumonia. It's available as an oral, well, not obviously in our setting, but available as an oral and IV formulation, and has demonstrated quite good in vitro activity against faecium that is said to be almost equal to tigecycline. Then quinipristin dalfopristin is a mixture of a streptogramin antibiotic with in vitro activity against VREs. There was a FDA approval for the treatment of vancomycin-resistant Enterococcus faecium infections, and this was subsequently withdrawn. And it's largely due to its very poor adverse effect profile, and it causes quite a few metabolic interactions. Some patients have reported severe myalgia, arthralgia, hyperbilirubinemia, nausea, etc. And you also need a central venous access to administer the drug. Televancan is a lipoglycopeptide that has also been approved for complicated skin and soft tissue infections caused by susceptible gram-positive bacteria, including Staph aureus and vancomycin susceptible faecalis. There's really no clinical data regarding televancan use for other enterococcal infections, but it's said to be about fourfold more potent than vancomycin against enterococci. And that's the MIC for about 90% of the isolates in the US are said to be equal to or less than 0.1 micrograms per mole. Okay, then just a few take-home points. So we know that enterococcal hospital-acquired infections are increasing worldwide, and VRE is a WHO priority pathogen. We know that there are multiple resistance mechanisms described, and these seems to be changing as antimicrobial stewardship remains a global problem. Good IPC practices and surveillance is key in prevention. And I think that this also highlights the need for a One Health approach, and perhaps, like we said earlier on, can be used as an indicator to monitor antimicrobial resistance in the context of One Health. And that's the end of my talk.
Cool. Thanks so much. That's really nice, and you've covered a difficult topic really nicely. I see in the chat there's a question about the mechanism. So, ceftriaxone alone is obviously enterococci resistant to it, so it doesn't have any significant function. So then the question is why is it good as synergy? Because is it covering other potential organisms empirically? So no, it's not, right? This is using it just to cover ampicillin. And then do you happen to know the reason why for the audience?
No, I don't know the specifics as to why. It's just the most data is actually with ceftriaxone ampicillin combination therapy for endocarditis.
Yeah, so it's the different penicillin binding proteins. So the ampicillins 4 and 5, and that's usually the main ones. But then ceftriaxone binds different ones. I think 2 and 3, if I'm not mistaken. And so that do have an additional synergistic action, but not enough on its own to be to make it susceptible. So it's a kind of a weird thing, because it is a very, very, very good question. You normally think of ceftriaxone as being not a drug you can use for enterococci, but it's shoved right up there as the synergy of choice. And I agree actually with your comment about earlier. You were saying that ampicillin plus ceftriaxone versus ampicillin plus gentamicin for enterococcus, for endocarditis and things. It's absolutely baffling to me why anyone would choose gentamicin anymore. I know it's in the textbooks. I know it's still there. This is just one of those outdated things that needs to be just discarded. It's more toxic, gentamicin, and no better. And it should be in these endocarditis guidelines. I think should just be relegated to, I can't imagine why you would ever go there, really.
I think it really is just a force of habit, just to initiate empiric triple therapy in these patients. And, the thing that just comes to mind is Ampigenta and appropriate staph cover. But yeah, no, I agree. I think we should.
And I think for empiric therapy, you might get some benefit with some of those very resistant enterococci, I guess, or something like that, with the gentamicin, but specifically for enterococcus, I think if it's enterococcus and you want dual therapy, and of course, whether you want dual therapy is its own thing, but if you do, why you would choose gentamicin as opposed to ceftriaxone, I don't know. Anyway, but hopefully that'll filter through. Another question in the chat about saying how common is Enterococcus endocarditis in healthy volves following enterococcal bacteremia. You did kind of mention that a bit.
Yeah, so in our setting, like I said, we saw that pie chart, and that's very limited data, but that was 2% of native valve isolates in both culture negative and culture positive. So like I said, I'm not sure how reflective that is of our setting. I couldn't really find any other data aside from that, to be honest.
And then I know you did mention, but just I think the question maybe phrased also about when to screen effectively for endocarditis? I mean, when would you do it if you had an enterococcal bacteremia? If the person has, say, healthy bowel, should you still check for endocarditis? And in what scenarios, I guess?
So I guess in patients who have other risk factors for endocarditis and those who you can't actually find a clear source of infection.
Yeah. And I think the second one is, which you mentioned nicely in your talk, is a helpful thing. It is one of those good places to look if you have a bacteremia without an obvious source with endocarditis. Okay, and just looking through the chat. I think that's it in the questions, unless anyone else wants to add anything. That I saw you mentioned the pheromone responsive plasmids. That's really, really, really interesting. I mean, it's a whole topic in itself, but it's seems to be the particular one is really unique to Enterococca. You get other similar things, but that specific mechanism, which basically the recipient sends out a pheromone to the donor cell,
Yeah.
then gets a whole plasmid ready, or plasmid delivery system ready to hand over the plasmid to the recipient cell. It's a really fascinating thing, and yeah, not well known. Cool. And I guess last question, Tyral, for sort of controversies in that. Where do you think the biggest gap in Enterococcus research is? If you had one study that you think might change practice, what do you think? Where the big unknown? Where would you target your hypothetical $10 million?
Hypothetical 10 million. I'm not sure really.
In terms of maybe some of the other agents, or where do you think? In other words, what would, because vancomycin is awful as a drug, ampicillin is difficult. If you had, I guess, something you couldn't use ampicillin for,